In the past 5 months, we've been working hard to get our semester started safely. To get us going in an organized way, I appointed 5 committees to monitor facilities, research, student life, academics, and perhaps most importantly, safety. After carefully listening to what universities were doing across the country and to CDC guidelines, we developed an approach to try to keep us safe and minimize COVID infections on campus. Our Safety and Incident Management Committee has done an incredible job, and they're all working overtime for our benefit. Given the number of questions and concerns we've heard from around the campus about testing and safety, I thought it'd be helpful to go over the plans we've set up and why we did them. The cornerstone of our safety depends on testing, isolating, contact tracing, and quarantining whenever we find active infections in students, faculty, and staff, and then on adapting our learning, public, residential, and dining spaces to socially distanced and masked operations wherever possible. All activities on campus are reviewed by our Safety and Incident Management team, and we've developed a strict discipline about what is approved and how it is conducted. The net effect of our activities is that we have a very low incidence of active infections on campus, much lower than a lot of big campuses across the country. So far, this system we've developed works. In the past months, we've had a lot of questions about how we measure and report, so let's go over that briefly. Up front, we knew we needed to be able to get test results quickly if contact tracing was going to be effective. So we elected to use the rapid antigen tests supplemented by PCR tests when needed. Given the shortages of machines and reagents and the high expensive testing, we knew we couldn't test everyone repeatedly, which is why we don't mandatorily test everyone. Several schools have started off with ambitious programs and backed off frequent testing because it didn't necessarily keep them safer. And there's no evidence to suggest that testing everyone on day one resulted in a safer campus, as we've seen in a number of large schools. So we followed CDC guidelines and elected to focus on 2 strategies to keep our campus safe. I asked our Chief Medical Officer and safety team and some of our statistically trained faculty to find a way to conduct meaningful surveillance testing. We based our program on a modified model that UT developed. Thus, we used surveillance testing done with a rapid antigen test on asymptomatic students to determine if there are any hotspots or signals of a surge on campus. Now, we also do clinical testing of those who are symptomatic or are identified as close contacts. In symptomatic individuals, we consider a positive test to be definitive. If any asymptomatic students test positive, we use a confirmatory PCR test because while the rapid test is 98% accurate, it will give rise to false positives. There is a charge for testing because our Student Health and Wellness Center accepts insurance, and our insurance contracts require that we can't waive charges arbitrarily and must charge everyone who comes in for any type of service, including COVID tests. That said, we cover expenses for any student who can't make the payment, and no student's been turned away. When someone tests positive, we notify the county, and we have a well-trained contact tracing team that's working full-time to identify and notify any close contacts. When someone tests positive and has a mild to moderate case of COVID, and it's been 10 days since their symptoms developed, their symptoms are improving, and they've been fever-free for 24 hours, they are no longer considered infectious or able to pass the disease on to others. In the case of close contacts, we know that it can take up to 14 days after exposure for symptoms to develop, meaning those that have been exposed need to quarantine away from others and stay off our campus for a few days longer to be safe. I've received a number of questions about why we don't mandatorily test all close contacts and reveal their identity to teachers and staff. Well, we can't force someone to test, and these results are a person's protected health information and are HIPAA protected, just like student information is FERPA protected. I've also received requests from faculty and staff to be tested in our Student Health and Wellness Clinic. The short answer is we don't have enough capacity to provide testing for everyone and still do what we do now. It is also important that you're under the care of your primary care physician for continuity of care. We are working with state agencies to provide free testing to any student, faculty, or staff member, so stay tuned for the dates and places where this service will be provided. I've also been asked why we don't shut down or quarantine a class if someone in it tests positive. Now, we've built our learning spaces around a safety paradigm requiring masks and social distancing as recommended by the CDC, and it is effective. To date, we have 0 incidents or evidence of community spread in any classroom space. Unless the people in the class have been close contacts, they're not tested, per CDC guidelines. Since we haven't identified a single case, we believe the CDC guidelines are effective and we'll continue to follow them. We ask everyone to please respect our procedures on this. I know some of you are concerned that individuals who've tested positive might not be isolating as required. This is a tough problem. If there is a significant concern, contact us because we can work with local health authorities to find an appropriate solution. They have more leeway and experience with these matters than we do, and we would rely on their expertise. Finally, we've been asked why our case numbers are so low, and if it's because we aren't doing enough testing. Well, first, our case numbers are low because the procedures and practices we've put in place work. And we ask everyone to please follow them and work with us to keep our campus safe. Secondly, the more we test, the more positives we're sure to find, assuming that the rate of infection is a constant. Now, we don't have the resources to test extensively, but the positivity rate of our surveillance tests to date is so very low that it does not indicate that there's a systemic problem. What would be concerning is if we found a sudden change in the infection rate, that is, the percentage of infected individuals in our tests. And that's why we do surveillance testing. I also want to note that here and across the country, students have become less willing to participate in surveillance testing, and this could become a problem in days to come. We display the data we have publicly and have included self-reported positives in our total case line graph. We will also show our positive and negative data for surveillance and clinical tests exclusive of the self-reports in our updated Health Alerts dashboard that will be posted after I give you this update. I hope you have a better understanding of what we're doing and that I've answered most of your questions. Please remember, we have a process that works if we all support it. Our teams are doing a great job, but keeping us safe depends on all of us taking responsibility for our own health and our community's health. Thanks so much for everything you all do, and go Mean Green.